The next speaker is Professor Gülüoğlu from Marmara Department of Surgery in Turkey, and he's going to give a lecture on the evolution of oncology in the last 20 years. Thank you, Professor Gülüoğlu.
Good afternoon, everyone. Thank you very much for the kind invitation. As always, I'm very much pleased to be in Athens with my colleagues here. And today I will be just following the nice talk given by my close friend Christos. He talked about what we had for the last 40 years in surgery, and that just coincidences with my career in my life in surgery, which started in 1991 with the radical mastectomies. Then at that year in Turkey, we started to do breast-conserving surgery. In my first case, we had the margin positive, and we sent the patient to the radiation oncologist in another department, and he sent back the patient again as margin positive. You need to do a mastectomy at that moment. Not even a re-excision was an option for those patients. But today, what we do, as the Christos just mentioned clearly, we are now having a margin such as no-income tumor, which was unbelievable at that time. And also, today, what we saw for the last 20 years, if I can pass to this, is that the neoadjuvant chemotherapy just now intervened our practice more and more. Why? Because we are having just in some subtypes, up to 70 to 75% of the time, we have a complete response proven by the surgical resections. So do we need to resect these patients that we know that 75% of the time there is no tumor behind? So why do we do surgery in our patients? In the historical wheel, there are two things. One is to provide longer survival, but by first doing the surgery in order to decrease the local regional recurrence. So is it so? For the last couple of years, we have more evidence accumulating now in our practice that although we are diminishing the size of the surgery, the rate of recurrences in these patients, although we're not doing sentinel nodes in all patients. We're doing sentinel nodes with positive patients and leaving the axillary dissection out of scope. And we're just doing oncoplastic surgeries or very limited breast-conserving surgery, even for two tumors with two lumpectomies. But now we are having less and less recurrence. Why do we have this? Isn't it a contradictory finding that you're diminishing your surgery, but your recurrence is also decreasing? So here, the first thing, yes, we should look for the local recurrence in our patient. But the second thing is, because you need to do a resection in your patients in order to find out the extent of the disease to decide the adjuvant treatment. Okay, so there are two reasons that we do it. So let's look whether these are rational things as a potential for non-surgical treatment in our patients. So for last 30 years, you know that before 2000, we were not thinking, neoadjuvant treatments in our patients who were operable. So only those with an inoperable patients, we were providing neoadjuvant chemotherapies at that time in order to diminish the tumor size, to make it a R0 resection possible in those patients. So, and for the last couple of years, another evidence showed us that if you give a neoadjuvant systemic treatment, regardless of the subtype of the tumor, if you have a PCR, the outcome is excellent, nearly 98% in all subtypes if you achieve a PCR. Therefore, if you have a good tool to treat your patients systematically, then although here all the patients had a surgery, but there's no difference in the survival in these patients. Yet, we have new drugs in pipeline. And these I-SPY 2 trials showed us that if you use a more advanced or more effective systemic treatments in neoadjuvant setting, you have nearly 80% of a response in certain subtypes of tumor. Even in the hormone positive, you are now receiving a 30 to 35% of complete response in your patients, which was less than 10% 10 years before. So what is the role or the potential of no surgery in our patients? So what are the gaps in knowledge? Because as an oncologist, not as a surgical oncologist, you need to know what is the remaining tumor size or what is the remaining extent of disease in the axilla is very, very important for you to extend your adjuvant treatment or to tailor your radiation treatment. So how would we be sure that the remaining tumor is there or not? And second thing is, if you omit your surgery, what is the local recurrence rate in your patients? So let's start with the gaps in knowledge for the determining the size of the remaining tumor. So we have MRI, but MRI is not excellent. It is better in the triple negatives and HER2 positive, but not excellent. So what about the new emerging technology like contrast enhanced mammography? Yes, it looks promising, but there's no difference whether you use it alone or in combination with MRI, so still they're not excellent. So of course, these are the imaging methodologies. So what about doing a biopsy? Not just dissociating a surgical resection, but doing a core biopsy or vacuum-assisted large bore biopsy. If it says that it is negative, there's no tumor, can we rely on this report? Yeah, there are some encouraging results, but again, they are not excellent. They are better than MRI, they are better than contrast-enhanced mammography, but not excellent. So when we come to a study from South Korea, they described a case like, for example, for the MRI. If the MRI appearance of the tumor is less than 5 millimeters, and if you did a core biopsy with more than 5 cores, then, especially in the HER2 positive and the triple negative cancer patients, the false negativity rate is nearly 0. It's 0 here, but I say nearly 0 because there might be some 1 or 2 cases in future, but it is 0, so accuracy is 100%. So therefore, if there is a combination of core biopsy or vacuum-assisted biopsy and MRI together with a good definition, with a good criteria, maybe we may sometimes estimate the complete response in these patients. So in certain subtypes, as I said, especially HER2 positives and the triple negatives, studies also showed us that with the vacuum biopsy, without incorporating MRI here, then the false negativity rate is also near 0, such as in this study from as a combination study with the Europe and the United States. So what is the long-term outcome if local resection is not done? So there's only one study. This is a phase 2 study from MD Anderson, and they included patients with the HER2 positive and triple negative. So if we are talking about the potential of a non-surgery, so we are just now talking only about these 2 subtypes. So in this report, in this study, there are only 31 patients. It's not too much. So half of them are triple negatives, and half of them are HER2 positive cases. So with a median follow-up of nearly 3 years, this is the latest report from the group, and they found no recurrence, 100% of survival, disease-free survival, and overall survival. So this is not surprising. Let's go back. For years, for the acute breast cancer, that means that by MRI, ultrasound, you didn't see the tumor, but there is an axillary metastasis. You found it, and what you did for years, we did mastectomies. But there were also other groups that did no mastectomies, only radiotherapy. And this meta-analysis or systematic review showed us whether you do mastectomy or give radiation treatment, whole breast radiation, there was no difference in local recurrence, in overall survival, and for the distant recurrence as well. So this is also critical for us to think that there might be a potential role of no surgery in these patients. So what about axilla? Is really sentinel node necessary in these patients? We know that the response to axilla is much better than the response in the breast. And this is consistent with many studies. So if you have a 50% of response in the breast, this is less or more is 60%. It's 10% more than the breast that you have. So here in this study with the 30,000 patients from the United States, they found that if it's a clinically node positive in the breast and there is a PCR in the breast, the likelihood of having an axillary metastasis is around 10%. So 88 to 90% of your patients in HER2 positive and the triple negative cancer patients, there is no axillary metastasis. So there is a potential to do sentinel nodes in here. I don't say that just omit sentinel nodes in today, but this is a potential for you to see for future. So another study, again from the United States. This is from this is a group from the United States from Boston, and they also found, this is an interesting, very small sample size, but it's just a hypothesis generating study. There were very small 60 patients with an N positive in the beginning. After the neoadjuvant systemic treatment with the anti-HER2 treatment, at the end, the response to axilla is 100%. So all of them had no disease in the axilla. Again here, MRI is useful to understand which patients have a good response to neoadjuvant systemic treatment. So if you put MRI, especially in HER2 positive and triple negative, which is understandable. Why? Because they give the highest possibility of response in the breast. So what about the hormone positives? So we said that there might be a potential for doing no surgery in our patients. But what about in hormone positives? Still, we don't have a satisfactory result for the neoadjuvant systemic treatment. But there is now an alternative for us to do a cryosurgery or a cryoablation. So as you know, all of you know that this ICE3 trial just published last year with the 5 years, this year, sorry, with the 5 years result. And again here, only the low-risk cancers, the hormone-positive tumors, we had nearly after 5 years, the recurrence is 3.5%. But wait, this is an overall result. If those patients who receive radiotherapy, when you consider these patients, the recurrence is 0. So when you look, there's a 3.5%. That's low, right? But as I can show you that only 15% of them receive radiotherapy. And when you look at those patients, there's no recurrence after 5 years. So that might be an alternative for the surgeons or the radiologists if you let them to do it, or if you would do this as a surgeon. So this might be an option for us to treat our patients even after neoadjuvant treatment. So as you know, last month the FDA approved using this device for this indication. So this is the new era now for the surgeons as well. So what about the staging the disease? Okay, you tell a good story for us, but we need the specimen in order to prove that there is no tumor behind. There's no other way to understand it. Well, you showed us MRI is not useful, vacuum biopsy may have a false negativity. What about this? So we depend on the TNN, right? TNM classification in order to decide what to do. But is it really cardinal for treatment decisions today? Now, today, if the axilla is positive by the core biopsy, the oncologist decides and the radiation oncologist decides whatever they would like to do. They don't depend anymore about, well, the extent of it. Yes, now we have CDK inhibitors, but now the new indications just includes only node positivity, not the number of the nodes anymore. Therefore, still we have a room for not doing maybe a surgery. So especially for, of course, the triple negatives and the HER2 positive, because the indications are so large for giving a systemic treatment in these patients. And coming to the tumor size calculation. Any pathologists here in the audience? I have one in my home. My wife is not a breast pathologist, but a GI pathologist, but she also acknowledges that they are not certain about it. When you put the same specimen to 10 different pathologists, they would give you 10 different measurements. So we are relying only on the pathology report and say this is 25 millimeters, let's give systemic treatment because it's over 20 millimeters. Well, the other says 90 millimeters. It depends on the unit that you're working and the pathologist you're working with. So it is not absolute. Please remember this. So now the prognostic staging includes the biological parameters, not anymore only on TNM. Now we incorporate the ER/PR positivity and also the gene profiling in order to stage the patient to decide on the systemic treatment. But this is now a starting era for the liquid biopsy. Now, please listen carefully here because this is not for today maybe, but this is the biggest evolution maybe in the coming 5 to 10 years, which would replace our surgery by itself, just showing you by just a piece, a blood sample will just tell you the faith of the patient maybe. Not clinically validated, but yet. So what is important here is that, if I can show you here, when you do the surgery here, because you don't see the tumor anymore. When you don't see the tumor, you think that you did a good surgery, there is no tumor behind. But the ctDNAs or the CTCs, the circulating tumor cells, maybe still there, and by this sampling, you can find it. Or during the follow-up, before it is obvious in your imagings and with the physical examination, the CTC and the DNA itself may appear in the blood, and this may warn you in advance to start a treatment maybe to prolong the survival. So there are many studies. It shows that in the upfront, if you have a CTC, it goes bad. I mean, the prognosis is bad in the hormone positive, triple negatives, and HER2 positives. Another one study shows us that if you do the CTC after the surgery, if there is, let's say, a positive CTC, and you don't start chemotherapy, as you can see, the relapse is high. But if you start chemotherapy according to the CTC, then the relapse is low. Okay? So this is a sign for us to use or incorporate the liquid biopsy into our practice. Another interesting study from France, they did a randomized trial. One group had received a systemic treatment, adjuvant systemic, according to the classical tools. I mean, you have the TNM, the tumor specimen report, and the other group received a systemic treatment according to the result of the circulating tumor cells. You know the result? It's the same. There is no difference between two groups. Whether you depend on your tumor staging, on your specimen, or you depend on the blood test with the liquid biopsy. So the interesting thing is, as I told you in the beginning of my talk, these are the last 3 slides. So I said that we should depend on something which is surgery to understand the extent of remaining disease. But here, again, liquid biopsy looks beneficial for us to understand the remaining disease here. Because again, why you are looking for the specimen? In order to find if there's a remaining tissue, the remaining tumor, that might be an indication that there might be tumor in the bloodshed and may metastasize, right? So why are you looking in an indirect methodology? Go and look directly to the blood to understand whether there is a floating tumor cells. This study is from Austria. They just published, I think, in 2022, and there was a good correlation between the pathological response and the CTC finding in the blood. Moreover, this is much more interesting. This is with a very small sample size. It is from the United States with 60 patients. Here, this group is the one with no PCR, but also positive CTC. That group is the PCR plus no CTC. So that's good. No remaining tumor, no CTC. This is bad. Why? There's a remaining tumor and the CTC positive in the blood. But this group is interesting. There is a remaining tumor in the breast, but there's no CTC, and they do well, like no tumor behind. So this is one of the potentials that you should consider for future. Now, I'm not saying that these are valid for now, but this is, my talk is the potential of non-surgery for future. Therefore, this is the second reason why we do surgery, to understand the extent of the disease. But these studies are showing us that finding the direct, not a surrogate marker, a direct marker for the disease recurrence for future. So in future, probably, genomic profiling, identifying tumor somatic gene mutation, circulating tumor cell DNA, microRNA will direct us for the real individualized and preemptive. That means still there's no sign of a recurrence, but there is an evidence with the CTC that the disease will come back. So this is the real preemptive systemic treatment indication in future, probably. So as a conclusion, so omitting surgery may provide an acceptable local control. For today, we are talking about HER2 positives and the triple negatives who had a complete response, clinically maybe complete response, plus you may add it to vacuum-assisted biopsy or MRI or something, but only under the circumstances where the patient receives whole breast radiotherapy. Without radiotherapy, now we cannot say that you can omit the surgery in these patients. And also liquid biopsy, seems to have a reasonable promise, not for today, to stage the disease before and after the systemic treatment without necessitating surgical confirmation here in this part. I did not put any sentence for a cryoablation, but you may consider that if there's a remaining tumor or in the upfront surgery, cryoablation may be a reasonable, alternative to surgery itself with the no recurrence, again, after 5 years in those patients who receive radiotherapy. But, however, of course, you need phase 3 studies before implementing these practices into your daily routine, life. So therefore, we need to plan and run those studies in order to find if there is really a role for a non-surgical management in our patients. So, if in future the pathological complete response replaces the surgical resection with these phase 3 studies, and if the liquid biopsy also replaces the pathological specimen assessment, then that's the day to eliminate surgery in our practice. Thank you very much.
I want to thank Professor Goulioglu for his excellent, very comprehensive presentation. And I believe that we must proceed with the next lecture and leave the questions at the end. Dr. Christodoulou Christos, he's a medical oncologist. He's the director of the Second Clinical Oncology Department of Mediterranean Hospital. Metropolitan, excuse me. Metropolitan Hospital.
You changed my hospital.
He will proceed with neoadjuvant. No, he will proceed with the evolution of oncology in the past 20 years. Chris.
Okay, thank you, Mr. President. I think I have to admit that Professor Goulioglu is a much better medical oncologist than I am. And I think that he should give this lecture instead of me. But anyway, since my friend Gregory Papadakis asked me to give this lecture, I have to do this. Thank you, Grigoris. I have to congratulate Grigoris not only for his medical and scientific expertise, but also for his social contribution with the MIS. So, I will try, after the two distinguished surgeons, I have to show you the evolution of medical oncology in the past 20 years, not 40 years as Dr. Markopoulos did, past 20 years. Okay, I think that during this period we had an astonishing evolution in medical oncology, and this evolution is much more impressive compared to any other tumor. Therefore, these are my disclosures. We do not only have chemotherapy and hormonal therapy today, but also targeted therapies, immunotherapy, and antibody drug conjugates. I will go through the last 5 decades to show you the evolution. In 70s, in systemic treatment, in 70s, we have doxorubicin for metastatic breast cancer, CMF in the adjuvant setting in node-positive breast cancer, and tamoxifen received the FDA approval for hormone receptor positive breast cancer, and actually tamoxifen is the first example of precision medicine since it targets the estrogen receptor, and I think that the first targeted treatment in breast cancer is tamoxifen. In the decade of 80s, we had nothing new in breast cancer from the point of view of systemic treatments. In the 90s, we had mainly supportive drugs, GCSF, antiemetics, the aromatase inhibitors. We had only other cytotoxic drugs like capecitabine, docetaxel, gemcitabine. And the first targeted anti-breast cancer drug of the modern era, the trastuzumab, which has also resulted in a Nobel Prize. in the decade of 2000, we had not much improvement. We have new cytotoxic drugs mainly, but here in the decade of 2010, a lot of targeted therapies, and these are the approvals, the FDA approvals for the last 4 years. Then you understand what sort of evolution we have in the systemic treatment in breast cancer. And I think that this evolution is based on the progress that we made in biology, the better understanding of molecular biology, and the improvement in biotechnology enabled us to produce drugs that are really very, very effective and less toxic than in the past. And I think that the key element for this evolution was the recognition of biological subtypes. Peru and Surly published a very interesting paper, a revolutionary paper actually, in Nature in 2000, and this paper enabled us to understand that in breast cancer we have to deal with 3 distinct biological subtypes. The basal-like, which is more or less what we call today triple negative, the HER2, and the luminal subtype. And we have evolution and progress in all these subtypes. I will start for early disease for practical reasons and then go to the evolution in metastatic disease. And let's start with HER2 positive breast cancer subtype, because we had the most important evolution in this field. As I said, for practical reasons, I'll start with early breast cancer and then I'll go to metastatic. You are all familiar with the use of trastuzumab in the adjuvant setting, and you all know the studies that established the use of trastuzumab. But we still have a lot of patients recurring. Therefore, it was evident that we need something better. And the better approach was to combine, to do a dual inhibition of HER2 by combining 2 monoclonal antibodies, trastuzumab and pertuzumab. These monoclonal antibodies are bound to the extracellular domain of HER2 in different epitopes, and this has resulted in the affinity trial in a better IDFS for patients with node-positive disease. We have today a very interesting formulation which combines these 2 monoclonal antibodies, pertuzumab and trastuzumab, and we can give these antibodies in 1 vial for subcutaneous injection. And I think that is very convenient for our patients. This is to do with their quality of life. As I said earlier, the dual inhibition of HER2 is more effective, but the dual inhibition can be achieved not only by combining 2 monoclonal antibodies that are bound to the external domain of HER2, but also we can use TKIs like neratinib, which targets the intracellular domain of the HER2. By giving neratinib after trastuzumab in the adjuvant setting, we can achieve an even better invasive disease-free survival in patients with HER2-positive and hormone receptor-positive disease. And also in the neoadjuvant setting, by administering neratinib to patients that do not achieve pathological complete response, we again can improve not only the invasive disease-free survival, but the overall survival as well. Neoadjuvant or adjuvant chemotherapy. This meta-analysis, which was supported by the FDA, showed that the PCR is associated with improved survival. And as you all know, the PCR is more common with the more aggressive molecular subtypes, meaning the triple negative and the HER2 positive disease. Therefore, in these subtypes, we tend to use more often neoadjuvant treatment today. These are the two historical trials, Neosphere and Trifina, that established the role of neoadjuvant treatment in HER2-positive breast cancer for tumors larger than 2 centimeters or with clinically infiltrated lymph nodes. I want to show you that in HER2-positive, ER-negative disease, we can achieve almost 30% pathological complete response by combining the two monoclonal antibodies without chemotherapy. This is something impressive, but the problem is that we cannot identify the patients who do not need chemotherapy. But it is impressive and it shows how effective are these drugs. For those patients that do not achieve pathological complete response, we have to escalate the treatment. Therefore, by administering TDM1, which is an antibody drug conjugate, instead of trastuzumab, we can achieve better results. And let's move to metastatic HER2-positive breast cancer. The historical trial with trastuzumab in first line, we said that the dual blockade is better than trastuzumab alone, and the Cleopatra trial proved that this dual blockation with trastuzumab pertuzumab is better than trastuzumab alone. But what after first-line treatment? After first-line treatment, we can give an antibody-drug conjugate. And here are the two antibody-drug conjugates that are approved for HER2-positive metastatic breast cancer. And you can see the differences between these two drugs, that the old drug is trastuzumab emtansine, and the new one is trastuzumab deruxtecan. And you can see that there are differences in the payload, in drug-to-antibody ratio, in the linker, and also this newer compound, trastuzumab deruxtecan, can achieve the bystander effect. This drug is directed against the HER2 extracellular domain, then it is internalized and the payload is released. Therefore, this kills the cancer cells, but also the payload, the cytotoxic drug, I mean, can penetrate to the neighbors and thus kills the neighbor cancer cells. This is the bystander effect. You can see that we can improve overall survival by giving this new antibody-drug conjugate in the second line. And in the third line, we can again give a dual blockation of HER2 by combining tucatinib, which is a TKI, and trastuzumab with capecitabine. And this combination has also impressive results in progressive brain metastasis as well. And from HER2-positive disease, let's move to luminal disease, the hormone receptor-positive disease. You all know, the surgeons especially, you know better than us, the hormonal compounds, tamoxifen, aromatase inhibitors, and fulvestrant. And these are the drugs that mainly benefit our patients in the early setting, but there are a few patients that need chemotherapy. How can we identify these patients? We can identify these patients by using genomic signatures, and the higher level for these signatures go to Oncotype and MammaPrint. We also showed in a series of clinical trials that prolonged hormonal treatment in the adjuvant setting can result in better results, especially in high-risk patients. Therefore, today we tend to give more than 5 years of hormonal therapy, either by switching from tamoxifen to aromatase inhibitor, or by starting with an aromatase inhibitor, or by giving 10 years of tamoxifen. The most important progress in the treatment of luminal breast cancer the last year is the use of CDK4/6 inhibitors. These drugs were initially used in the metastatic setting. These are the 3 drugs, the CDK4/6 inhibitors that are approved: palbociclib, ribociclib, and abemaciclib. But after the metastatic setting, these drugs were tested in the adjuvant setting, and they proved that they are effective. The monarchy trial showed that abemaciclib in node-positive patients can improve the DFS. And in the NATALY trial, we showed that we can do the same with ribociclib, not only in node-positive disease, but in node-negative disease, but high risk according to the oncotype, to the genomic signature. In metastatic luminal breast cancer, these compounds, the CDK4/6 inhibitors, showed a better progression-free survival, and one of these compounds, the ribociclib, also showed a better survival in patients receiving a combination of hormonal therapy and a CDK4/6 inhibitor. But what can we do when the disease becomes refractory, hormone refractory? We found that in these cases the PIK3CA pathway is activated, and therefore we can target this pathway. There are 3 drugs that we can use to target the pathway: the everolimus, which is an mTOR inhibitor, the alpelisib, which targets the PIK3CA, and also the capivasertib, a newer drug, which targets patients with PIK3CA, AKT1, or PTEN alterations. All these drugs are effective drugs, but they are difficult drugs. They have a lot of toxicity, stomatitis, rash, hyperglycemia, difficult drugs. Probably capivasertib is a more convenient and less toxic as compared to the other 2. Another way of developing resistance to hormone therapy is the mutation of ESR1. And we know that by using elacestrant, we can achieve better results in terms of progression-free survival. But we have to admit that the PFS is not impressive. And what can we give to our patients after progression to hormonal therapy? In the past, we had only chemotherapy, but nowadays we have the antibody-drug conjugates. I mentioned earlier the trastuzumab deruxtecan, which targets HER2, and we know that in luminal breast cancer, we have 65% of patients with HER2-low disease. And since this drug has a bystander effect, we can use the drug in HER2-low disease, and we can increase survival in the hormone receptor positive cohort. This drug was tested against chemotherapy in the first line in the DESTINY-06, and it showed a better overall survival, and therefore it has been established as first-line treatment after hormonal therapy. Another antibody drug conjugate that is active, that is efficient, is the sacituzumab govitecan, which targets the TROP2 protein that is usually found on the surface of breast cancer cells. And finally, the most difficult molecular subtype to treat is the triple-negative breast cancer. But during the last years, we had impressive progress in this field. The most important, I think, trial is the Keynote 522, which established the role of pembrolizumab, a checkpoint inhibitor, in the neoadjuvant setting. By combining pembrolizumab with chemotherapy, we can achieve a higher PCR and also a better event-free survival. What about the patients that do not achieve complete response? We have to escalate the treatment in these patients. We can escalate the treatment by administering capecitabine, and today we tend to give a combination of pembrolizumab with capecitabine to these patients. But we should not forget that we have PARP inhibitors like olaparib, and in patients with BRCA1 and BRCA2 mutated breast cancer, the Olympia trial in the adjuvant setting showed that there is an overall survival benefit with a 32 reduction in risk of death versus placebo. Therefore, in these patients, we can administer olaparib in the adjuvant setting. And as far as it concerns the metastatic triple-negative breast cancer, again, we have immunotherapy, pembrolizumab in combination with chemotherapy as first-line treatment. And we know that in PD-L1 positive disease, this combination can improve overall survival. And in the second line, the antibody drug conjugate sacituzumab govitecan is better than chemotherapy, and it improves the overall survival. For patients that are BRCA, BRCA1 and 2 mutated, the Olympiad and the BRCA study showed a benefit with the PARP inhibitors, olaparib and talazoparib. And these inhibitors were found to be more effective than chemotherapy. And with all these compounds, we have increased the 5-year survival of breast cancer patients. We have reduced the mortality. And I will conclude saying that the breast cancer treatment is becoming more personalized as doctors learn more about the disease. It's now seen as a disease with subtypes that have different patterns and ways of acting on the body. Special tests can help doctors, oncologists, to define the best treatment. And additionally, targeted and biological therapies may allow us to avoid chemotherapy or delayed chemotherapy in a lot of our patients. Thank you very much.
Thank you so much, Christoph, with your excellent lecture and the way how you cover the last 20 years of evolution in oncology. I believe that we must proceed with the next lecture, and we'll leave questions at the end if there are any questions. And I want to call in the podium Professor Dueck, his lecture will be for the neoadjuvant chemotherapy in the early breast cancer and different perspectives.
Thank you to the organizers for inviting me to the city where I was born, actually, Athens. It's always a pleasure to come back, but I do hope that you will still want to invite me after you hear my talk. It's not working, sorry. So I've got no disclosures, unfortunately. I've moved to the University of Oxford 5 years ago, and you can see here are medical graduates, women graduates in 1920. And this is one of the 39 colleges, it's Christ Church College, which houses this hall, which is where King Henry VIII held the English Parliament. So the English Parliament was actually in Oxford, but of course it's famous for the Harry Potter movies. And this little office here is the room of this man, Albert Einstein, when he was professor at Christ Church. And he received the doctorate honoris causa from Oxford in 1931. This is our Department of Surgery, which opened in 1938. And this is the Order of the British Empire, which was given to my head of department, Professor Hamdi, earlier this year in June, and he's the only surgeon to have received an award on that list this year. So, a few words about surgery before I move on to neoadjuvant chemotherapy. I don't need to remind this audience that surgery comes from two Greek words, cher and ergon. It's to do with handwork. It's not to do with a scalpel. It's not to do with a knife. And in the UK, surgeons were not medically qualified until the late 18th century, where an act of parliament forced us to become qualified in medicine. And this is why in the UK, we are still called Mr. unless we are Professor. And in fact, I'm quite happy for people to call me Mr., but I really dislike it if they call me Doctor. And I'm sure you would agree that fundamentally, surgery is very, very different to medicine. And it's fundamentally different because it's not only a science, but it's also an art. But remember, it's also a science. Now, neoadjuvant chemotherapy, when we give it, what is it that we are trying to do? Well, initially, the reason why we gave it was because we wanted patients to become operable, and it made sense. Then we asked the question, well, perhaps we can improve overall survival with primary chemotherapy, and the answer was no. And that is being published in the Cochrane Review. But for some reason, we still feel that we need to do it. So what are the underlying hypotheses that we are accepting by giving neoadjuvant chemotherapy? Well, we believe that breast cancer is a systemic disease, and that primary chemotherapy improves overall survival, that the tumor does not spread whilst we're giving chemotherapy. It somehow stops to spread, and that breast cancer is caused by just one single clone of cells, and that the tumor is always unifocal, and you shrink it, and therefore it shrinks unifocally, and that the oncologists can see the tumor shrinking and confirm response to the chemotherapy, and that there are very high PCR rates, and so forth. Increases rate of auxiliary conservation, improves breast conservation rate. Unfortunately, none of them are the case. The only one that has level 1 evidence is the last one. Primary chemotherapy improves breast conservation rate. Now, our thinking of breast cancer has been heavily influenced, as was mentioned by the last speakers and by Professor Markopoulos, by two great American surgeons. William Halsted, who believed that radical treatment was the way forwards, and if you treated patients radically, you cured them. And of course, you did in selective patients. And Bernard Fisher, who said, no, this is a systemic disease, and therefore the diagnosis and the prognosis are predetermined. When you diagnose the patient, the prognosis is already predetermined. Now, who was right? Now, another surgeon, Roland Rosier from Paris, published his 32,000 series of breast cancer patients. And he published them for the purpose of showing that chemotherapy works. But of course, we know that chemotherapy is important and chemotherapy works. But I'd like you to focus on the no chemotherapy arm, where patients received no chemotherapy. 88% of them survived 5 years, and 75% survived 10 years. And what does that tell us? it tells us that surgery and local treatment are most important, and they probably cure about 2/3 of patients, and about 1/3 of patients benefit from some form of systemic treatment. And why is that? And that is because surgery has a systemic effect. We are dealing with a metastatic disease, and when you take out the tumor, you switch off the tap. There might also be some serendipitous effect on metastasis, but I think the data is a bit unclear on that in the literature. Surgery works on all subtypes, so it doesn't matter what the subtype is. If the tumor has not spread, which is more likely in 2024 than it was at the time of Halsted with screening, then the patient will be cured. The treatments to avoid are the ones with the less side effects. So of course there's a place for avoiding surgery in patients who need chemotherapy. But it's much more important to try to eliminate chemotherapy as much as possible, given breast conservation and sentinel node biopsy has minimal toxicity. There are a significant number of patients who decline systemic treatment. So surely it's important to try to get the surgery in early. Now look at the logistic of it. Clearly, what we are trying to do is to diagnose patients as quickly as possible and treat them as quickly as possible. And the way to deliver all treatments as quickly as possible is by giving surgery first. Because if you give chemotherapy first, you delay surgery by 5 to 6 months, because chemotherapy takes so long to deliver. I believe there's a mindset problem with chemotherapy, that we still believe in 2024 that primary chemotherapy must be given first because breast cancer is a systemic disease, and that surgery is just a local treatment. All we're doing is taking the tumor out and providing material for our better and more intelligent scientific colleagues who are carrying out experiments in the laboratory. And by giving primary chemotherapy, we can avoid surgery altogether, and therefore we think, well, let's go down that bandwagon. But unfortunately, the truth is very different from this reality. Now, what are the drawbacks? You might say, well, actually, if a patient needs chemotherapy anyway, what's the problem? Let's give it before surgery. Well, first of all, most importantly, there's no survival difference, and it leads to more chemotherapy. If you give patients primary chemotherapy, you then decide which patients are suitable for extended chemotherapy. And guess what? That means more chemotherapy, not less chemotherapy. Overtreatment. Patients, unfortunately, the radiotherapy is still determined by what the original primary extent was and not by what they have now. So unlike us surgeons who have now eventually accepted breast conservation, our clinical oncology colleagues are still struggling with trying to give less radiotherapy to patients. And for example, treatments like intraoperative radiotherapy are not even considered, let alone given to selection of patients. But most importantly, the detrimental effect on the most important treatment, which is the detrimental effect on surgery. And this is why. Primary chemotherapy can end up in several endpoints. You could have a tumor that ends up in lots of pieces. You could end up, as I said, with one lump that has shrunk, or you could end up with several lumps. And of course, we all want patients to have that, which is nothing. And of course, a lot of members of the MDT celebrate when they see nothing. I don't. I think this is a pathological and surgical nightmare because the pathologist doesn't know what to tell us, the radiologist doesn't know how to guide the surgeon, and none of us know whether we have taken enough tissue or whether the surgery was adequate. So, if you like, clipectomy, which is where you stick a clip into an area and take out a chunk of tissue, is never going to be an adequate surgical operation. So let's dispel some more myths. The 3 myths are that patients who are triple negative, those who are HER2 positive, and those who are node positive should all have prime chemotherapy. Wrong. No evidence for any of this. Let's look at one of the studies that was mentioned earlier. The trial was Neosphere, and the other one is Cleopatra and Trofima. They've all shown very dramatic effects in the neoadjuvant setting, but guess what? When you ask the question, pertuzumab, how does it fare in the adjuvant setting? The Affinity trial showed with more than 4,000 patients that there is a tiny difference of 0.9%, which is, you could say, statistically significant, but I would say with 4,000 patients who are HER2 positive, it's clinically insignificant. And certainly you just have to look at the curves. They're on top of each other. What about capecitabine? Well, I will refer you to the Cochrane review from 2021 that shows no benefit of capecitabine for PCR was noted overall or in hormone receptor subgroups. But there is a place for capecitabine in the adjuvant setting. So we need to do more in the adjuvant setting. What about the PCR myths? Dramatic results in PCR do not always translate into better overall survival. These studies have shown you. But there is a very important fact, and that is that the CT NeoBC, which was published in Lancet Oncology and was mentioned earlier by my colleague at the last talk, it actually shows, if you look at the 12,000 patients in 12 studies, if you read the bottom, our pooled analysis could not validate pathological complete response as a surrogate endpoint for improved event-free survival or overall survival. In other words, PCR, unfortunately, is not related to survival or event-free survival. And the graph looks like this in that paper, scatter diagram. And you can believe this, it's all oncologists, don't worry, there are no surgeons in the authors. There's a scatter diagram. In other words, the extent of PCR is not related to the outcome. Of course, when you see a patient who has responded to treatment, they're going to do better than a patient who hasn't. But when you pool that analysis, you don't get a linear relationship. What about the holy grail of histopathology? Well, I worked out with Professor Vaidya and a statistician that if you analyze the amount of tissue that a pathologist looks at to declare the specimen as PCR is 1,000th of the size of the tumor. And that if the pathologist had to lay eyes on every single cancer cell or every single section, it will take them too long. You can see 20,000 sections will need to be examined. It will take 3.5 years. So with the assessment that we do, the eyes of the pathologists have laid onto about 1,000th of the amount of tissue that was taken out by the surgeon. What about HER2-positive patients? That's the Catherine study. This is a study where over 1,500 patients received primary chemotherapy, then they were randomized to T-DM1 or Herceptin. And what people forget is 25% of those patients were inoperable when they presented. I can't remember the last time when I saw an inoperable patient with HER2-positive disease. They're mostly operable. But with this very, very large series, they showed no difference in overall survival and an impressive difference in invasive disease-free survival. But of course, what we want to know is what will happen to patients when they have surgery first. But that's not even in the paper. The most mature data was presented at San Antonio and showed overall survival difference between these two arms. That paper hasn't been published yet. But it still doesn't tell us what we want to know. So the funders of these studies are telling us what they want us to see, but they're not telling us what we want to know. And the simple question I want to know for my patient is if I have the surgery tomorrow and I have T-DM1, will I survive more or less than those two arms? And that's not there. And that's called investigational bias. Then there is the EBCTCG meta-analysis of 2018 that looked at the important neoadjuvant versus adjuvant trials. These are my colleagues in the building next door, in the EBCTCG group at University of Oxford. And they showed that there is a 5.5% increase in local recurrence with primary chemotherapy. Increase. Now, I can understand that some clinicians think that this data is not very good and it's historic. I get that. But has that been shared with patients? No. And if not, why not? And if you think that with novel anti-cancer treatments, that difference will be smaller, I would agree with you. But if you try to convince me that that difference will be reversed, then I would say I don't understand the biological assumptions you're making to come to that conclusion. So I think with modern treatments, we can say very safely that the difference in local recurrence will be less against neoadjuvant chemotherapy, but it's never going to be reversed. What about breast conservation? There is a 16% improvement in breast conservation in that same meta-analysis. But I would suggest to you that you can get a much better increase in breast conservation by changing the surgeon. So I still travel all over the world and I see surgeons offering mastectomy. 16% difference between the arms, for me, is very, very modest, given I know that there are still a lot of mastectomists out there. So the EBC-TCG meta-analysis on neoadjuvant chemotherapy, which incidentally is the one that everybody forgets about, the other ones are very well advertised, this one isn't, has shown that breast conservation is increased, and that there is a 5.5% increase in local recurrence at 15 years in those patients who received neoadjuvant chemotherapy, and it showed no effect on overall survival. Not because it's not there, because it probably is, because we know that for every 4 local recurrences that you save 1 life. We know the 4-to-1 rule. That also came from a meta-analysis of EBC-TCG. It's because the power wasn't there. It was not a superiority intention there. So we didn't have the power to say that there is no detrimental effect to survival with neoadjuvant chemotherapy. So if you think I'm radical, then please read the paper by Professor Vaidya, because he's far more radical than I am. I'm not against primary medical treatment. In fact, I'm the chief investigator of the EndoNet trial. I received a £3 million grant to ask the question of should we operate at 6 weeks or at 6 months in patients who are suitable for an aromatase inhibitor. So we're going to randomize about over 1,000 patients, and we've already randomized 144 patients from 32 sites in the UK. But there are other issues which I don't think I'll be able to cover in the time that I have available, so I'll try to be as fast as I can. You will ask me, well, actually, fine, but what about ultrasound and biopsy of the nodes? What about targeted axillary dissection? What about personalized care? Well, targeted axillary dissection, the clipping of a node and doing sentinel node biopsy in node-positive patients after chemotherapy, I was very excited about it, and I wrote this piece. But then I realized that actually quite often it turns out being involved, and you just go back and do an axillary clearance in a selection of patients. And most importantly, that it amounts to undertreatment, because we still don't have level 1 evidence supporting this practice, particularly in patients who have more than 2 nodes involved at diagnosis. And then there is the clip and excise data. If you see this in a journal, you'll feel embarrassed to be a surgeon, because that is the data that we use to do clips. It's 103 patients, 44 patients, 104 patients. There is nothing else. There's no evidence at all. Primary chemotherapy makes patients ineligible for Z11 and Amarose because the patients who had primary chemotherapy were not allowed into those trials. So once you've had your primary chemotherapy, you cannot apply Z11 or Amarose to those patients. They lie outside of the published data. So a few years ago, my PhD student, Munir Ahmed, and Felix Jostja, who was a medical student at the time, we did a meta-analysis, and we looked at patients who are diagnosed by the radiologists as node positive with an ultrasound and a needle, and compared them to those who have a sentinel node biopsy and are found to be node positive at operation. And we essentially looked at patients set them up into 2 groups: those who had low burden disease, in other words, they meet the Z11 criteria, and those who don't, who have node positive, heavy node positive disease. And what we found was quite astonishing, that about 43, nearly half of patients who are diagnosed by the radiologist with an ultrasound needle would have qualified for Z11, which means that when you have a good radiologist sticking a needle into your node, you are then in a situation where, as a surgeon, you can only do axillary clearance because you don't know how many nodes are involved, or irradiate their axilla. So you're fast-tracking them for treatment in the one area of breast surgery where you want to do de-escalation. And in the future, what I would like to see is patients having a core biopsy just if there's an abnormality, not a cortical thickening, not a little bit of fat, a proper metastasis, which you can see here at the bottom right. A proper metastasis in a node, that's what needs a biopsy. Anything short of that, any little bit of fat, cortical thickening, they should all be left alone, because sentinel node biopsy, unfortunately, is the most reliable way in 2024 to stage the axilla. And this is what I mean, that if you start, if a patient needs a sentinel node biopsy, they have it, and then they can have Z11, in other words, nothing, or Amarose, irradiation of the axilla, or they can just proceed with axillary clearance. But if you fast-track them down that route, or you give them neoadjuvant chemotherapy, At best, they can have a targeted axillary dissection, but everybody else who's had primary chemotherapy cannot have Z11 or Amarose because we just don't know. We don't have the level of evidence for that. We also have Oncotype DX, and in the UK, we now offer Oncotype DX to selected node-positive patients. And of course, the great excitement is about personalized care. And personalized care is great, but there's a very fine line between personalized care and anecdotal treatment. In other words, see one and then change the chemotherapy treatment and then do something else. Because that, in my book, is still called anecdotal treatment. So we have to be very careful not to present anecdotal treatment as personalized care, because it isn't. We still need adjuvant trials. We still need data to be able to do personalized care. So that's my last slide. So what do we do now? Well, I still offer surgery first. And I offer surgery to those patients who need a mastectomy and who cannot be downsized to breast conservation. I offer breast conservation to patients who are suitable for breast conservation today, but I'm respectful of my oncology colleagues. And if they, at the MDT, recommend neoadjuvant chemotherapy, I would also offer the patient neoadjuvant chemotherapy as an option. But I find it impossible to sell that option, given the evidence that I've just shared with you. And I think we need to try and avoid offering patients neoadjuvant chemotherapy as a form of access to new drugs, because shrinking a tumor significantly is not the same as saving a life. So just be careful about access to drugs, because all you're doing is you're escalating the cost of care all over the world. And I would really plead for all of us who are interested in clinical trials, we need more adjuvant trials. We cannot just look at these neoadjuvant trials and think all of a sudden we have saved money and we can do these trials and change practice. We can't. There's no easy solution. You have to have the adjuvant trials, because they often show something different from what was seen in the neoadjuvant space. Thank you.
Thank you very much, Professor Duek, for this excellent, very detailed, referenced, and thought-provoking lecture, underlying the caveats of modern woke treatments. And as Professor Markopoulos said earlier, we might see some old surgical habits coming in the spotlight again in the future. Perhaps we should leave the questions for later and proceed with the commentators.
That's very kind of you.
Thank you.
Thank you.
Thank you very much. So our first commentator is Dr. Ignatiadou, who is a surgeon at Erikos Dinan Hospital. Thank you.
I would like to start. Good evening to all of you. I would like to start by thanking from my heart the organizing committee and scientific committee, especially the President, Dr. Papadakis, and Vice President, Dr. Maragoudakis, for this opportunity to be part of this excellent session, prestigious session, I would say. Second, but I think of the same importance, I would like to take this opportunity and to thank all these pioneers, as Professor Markopoulos, as Dr. Papadakis himself, and many, many others that are not here in this room, who had taken the road less traveled in an era that introducing new surgical approaches was considered in some days and some ways insane and even malpractice, and daring to follow the scientific results. This was the way to open our road for us, the next generation, and even I would like to thank the first women in this specialty, such as Irini Karida, who were the first female surgeons dealing with breast cancer. As for our excellent speakers, each of them had gave us a different perspective. I'm a breast surgeon, so this is my disclosure of interest, and I cannot ignore that our role is changing. I would not say that it's being eliminated, but I would say it's changing, getting more pivotal in the frame of a multidisciplinary team and board, where we have to open up the spectrum of our knowledge and realizing that our role is getting very, very important. For example, we are the first to see a patient, so we are the first who has the opportunity to stage the disease. And I cannot say thank you, I cannot avoid to say a great thank you to Professor Dueck for really thinking out of the box and speaking out loud what we all breast surgeons are thinking. And I would not like to be more specific on this. And Professor Güloglu has posed many questions for the future and has underlined the necessity for us, the breast surgeons, to be more involved and dealing with many detail with what is coming, such as genomics, biological futures of the disease, and so on. Thank you for your patience.
Thank you, Dr. Ignatiadou. Dr. Caparellu. Excuse me, Caparellu. It's written. There's an error. So, Dr. Caparellu is a pathologist at EASO, at a medical oncologist. They're both wrong in the little book. I was wondering if you would like to give us your comments. Thank you.
To thank the organizing committee and Dr. Xepapadakis for the invitation. I congratulate all four speakers for their excellent presentations. As far as breast surgery, I think that the evolution is it reflects an inspired journey that improves the functional and the aesthetic outcome of these women, while preserving the well-being of them. Because I'm a medical oncologist, the past 2 decades, there's much advances in new drugs. We have seen immunotherapy. We have new drugs like CDK4/6 for HR-positive breast cancer. We have ADCs. We have much great advancements in this era. The future, I think, would be about prevention of cancer. And we will not talk about how we do the best surgery or have much more drugs to give to our patients. It's very nice that we have all these things. As far as the last speech, I would say that I'm not sure that we are ready not to use neoadjuvant chemotherapy. And it's not like I'm saying that because I'm a medical oncologist, but I think it's very important to give the surgeons smaller tumors, and it's important to see the biology after chemotherapy, the molecular biology, and bring the new drugs in this setting. Thank you.
Thank you very much. And last but not least, I would like to ask Dr. Stafila to give us her comments on these lectures, please.
Yes, thank you very much. Thanks for the honor to be invited to this very interesting session. I enjoyed all the talks. They were obviously controversial. I'm a breast surgeon. I'm the younger generation of the breast surgeons. I believe that the role of the breast surgeon is not just to operate. We're not artists. We don't perform just the art, like Professor Dueck said, but we're also science. And as such, we should see our role being transformed within the multidisciplinary team. So we're not here just to perform operations, but we are here to treat our patients, to do the best for them. And as we look back towards the past and as we look at the evolution of breast surgery, we cannot disagree that it goes towards less and less surgery. So that's a river that cannot go back, I think. So whether we operate, whether we do like small lumpectomies or vacuum-assisted excisions, or we count the CTCs or whatever we do, I think that we're still going to be breast surgeons, and the breast surgeon has to be the lead clinician of the MDT, because it's all about decision-making. And we need to have deep knowledge of oncology, not just to have knowledge of art, of performing operations. Thank you.
Thank you.
A little bit delayed.
I don't know if Professor Akadopoulos would like to say something.
Thank you. Just for the sake of time, I just want to say that this was one of the best sessions that I have attended in similar conferences, and congratulations to all.
Thank you. Thank you. I don't know if there are any questions before to proceed to the next satellite symposium. Yes, Dr. Papadopoulos.
Thank you so much for all the beautiful talks. I have nothing to say, and I deeply admired all the things that you've said. But Professor Dueck, can I ask you something? Because you said about the EBCT-CG trial, right, and the meta-analysis. And of course, it's a very important paper, but I'm sure that there are some cons concerning this meta-analysis, that we had a lot of old trials, no new drugs, no magnetic resonance, right? Patients that were not operated at all. You said that it would not affect the result, or at least change it. Is that what I understood? Yes.
So the answer is very, very simple. That all those trials were, as you said, old chemotherapy treatments and all the rest of it. But those same trials are the same trials that we use today to recommend primary chemotherapy. So on the one hand, we are saying they're not good enough to show what we don't want them to show, and they show it. 5.5% increase in local recurrence at 15 years, which, as I said, if you share that with a patient, I promise you they'll be walking out the door that instant. And the second thing is that we're saying it's sufficiently strong to recommend neoadjuvant chemotherapy. We can't have it both ways. So if they're not good enough, which I agree, let's not give neoadjuvant chemotherapy and let's do more trials, which I'll be in favor of.
Okay, one more question? No one. Okay, okay, please.
Thank you very much for this very, very excellent session. Professor Dueck, as a breast surgeon, I'm coming to you too. I think the whole of medicine is an art. That's why we say lege artis. Especially surgery is an art and science combined. The whole medicine is like that. The thing is, can we speak about neoadjuvant therapy in general? In your last slide, you recommended that we would do mastectomy in a patient where perhaps neoadjuvant therapy is not indicated. I think if you combine science and art in some tumors, like the HER2 positive and the triple negative tumors, perhaps you can avoid mastectomy by doing a therapeutic mammoplasty, for instance. I think some patients really benefit from neoadjuvant therapy. On the other hand, there are many patients who would not benefit and who would have the local recurrence. So perhaps we have to have trials to separate these subgroups in order to get the best out of it. And I agree about the Z11. They have a huge minus, that they miss this opportunity.
But if we do that, if we try to achieve what I agree with you on, the trying to find that group of patients who could have breast conservation, what we call now in the literature extreme breast conservation. The way to do it is by designing clinical trials and by continuing to do adjuvant trials on the exciting findings on neoadjuvant ones. But we're not doing either of these. What we're doing is going down the anecdotal route. We're telling patients, let's give the chemotherapy quickly because that's going to be better for you when it isn't. And we're going to give you chemotherapy when we know you're going to have a mastectomy because you might get breast conservation. But if you dig deeper, it's still because we have this mindset problem where we still believe that we're doing the right thing when the evidence is telling us that we're not. I'm completely in favor. If you design that trial, I'll recruit into it.
Thank you very much. I think a lot has been said, and it's been said by very prominent researchers and scientists and teachers of us all. So we might as well think about them and study about them and continue in the next round table, perhaps next year, hopefully, or even shorter. I don't know. Thank you very much.
Thank you.